Welcome back to the Oncology AI Lab. Today, the stress test is going to do something different. Instead of giving a case that has a clearly defined answer, we want to test how the AI's clinical reasoning is when there are multiple correct answers and when there are no head-to-head clinical data to support it. The case is about stage 4 EGFR mutated non-small cell lung cancer. As you guys know, there are quite a few options in this space. In 2024, there are 2 new combination approvals, certainly quite some time ago by oncology standard. Osimertinib plus chemo from FLAURA2, and also the MARIPOSA regimen, amivantamab with Lazertinib, both comparing to Osimertinib monotherapy with quite a bit of improvement that way. So certainly the combinations are strong consideration for most patients who are able to receive it. Because of those relatively new data and the fact that there are no head-to-head trials between those regimens, I want to see how the AI will handle this gray zone. Let's begin. So you guys can see the prompt here. 65-year-old woman, non-smoker, EGFR mutated non-small cell lung cancer, biopsy proven metastatic lesion. And we're asking it how it would manage the case. Now, if we ask it to search first, it'll do just that. However, the fact that the FLAURA2 and the MARIPOSA regimen are both approved back in 2024, way before the training data cutoff date, I want to see whether those options are surfaced. As you can see, it did not do the search first, and it correctly highlighted that the EGFR mutation is the main consideration here. Their first-line treatment, it actually cited Osimertinib monotherapy, which we just mentioned. The FLAURA2 and MARIPOSA regimen are superior that way. But of course, single agent is certainly better tolerated. It correctly highlighted here that immunotherapy should not be considered given the EGFR mutation that we just mentioned. And here it did mention the FLAURA2 as a consideration for the first-line therapy. So it's good to see that this is being highlighted. And interestingly, even though the regimen is approved and the AI has access to it before the training data cutoff date, it seems that the newer analysis has not made it into it. So the AI still thinks that the data is immature, but those have actually been updated already. Then I mentioned the pleural infusion management, the workup. So first-line therapy, it mentioned either monotherapy or the FLAURA2 combination. So what I do not see here is the MARIPOSA regimen, which is the amivantamab plus the Lazertinib. Let's figure out why this has not been surfaced, despite the fact that this should be available before the cutoff date. So we specifically prompted, why did you leave out this particular regimen and will you consider it? So it seems like the AI actually has access to it, so it knew about it as is able to list it here. And it highlighted the fact that it was omitted because the other regimens are more widely adapted, and also mentioned some of the guidelines. However, we know based on the more recent guidelines, that's not necessarily the case. And here again, proving that it has access to the trial data here. Also noting the overall survival data is actually matured already. So the knowledge recency gap is an issue for this particular case. Again, highlighting that the approval was way before the cutoff date. And here it's performed a cross-trial comparison without much of a caveat. I think this is the right answer here, that certainly those options are all reasonable based on individual patient preferences, logistics, and so forth, and certainly the treatment should be individualized. But I would prefer if we saw all 3 of the options listed as potential options. We've tested this exact same prompt with OpenEvidence and DocsGPT. OpenEvidence was able to list all 3 from the first go without additional prompt. DocsGPT actually only listed Osimertinib monotherapy. It didn't mention FLAURA2 or MARIPOSA at all. If you guys are interested, the analysis are in the Substack. What I think happened in this particular case with Claude is that even though the AI has access to this within its training data, the overall survival was immature at the time. which probably caused it to weigh differently despite the approvals. And because the training data density is much denser for osimertinib, that's probably why it favored it at the beginning. So certainly those are pitfalls that we should be aware of for large language model AIs. The training density can change its preference. Now, to push it a little bit further, trying to surface more of its clinical reasoning, we'll be asking how it would sequence those therapies based on different first-line options, meaning what it would do after osimertinib monotherapy, what it would do after FLAURA2 and MARIPOSA, and so forth. And of course, in actual clinical practice, those probably based a lot more on the resistance mechanism and the molecular profiling at the time of progression. But certainly more of a thought exercise now to see how the AI demonstrates clinical reasoning. So after osimertinib progression, it correctly highlighted that trying to get repeat molecular testing with repeat biopsy, either liquid or tissue, makes sense to identify the resistant mechanism. And it mentions some of the different options here, MARIPOSA 2 as a potential option. Now, even though amivantamab plus lazertinib has been listed as a second-line option, it's not exactly what the MARIPOSA 2 has tested. So it's interesting that it's highlighting this now. It actually said just right over here, MARIPOSA 2 is testing amivantamab plus lazertinib with chemotherapy versus chemo alone. And of course, there's the other arm was amivantamab and chemo together without the lazertinib. So the fact that it's tying all these together, it's a little bit odd. All right, so next up, after progression on the FLAURA2, let's see what it recommends. And it actually spaced out here if the progression happened during chemo or after. This is a clinical consideration that I haven't quite built into the prompt. The fact that it's able to be more granular here, that's quite thoughtful. And again, kind of basing on resistant mechanism, so that's good to see. All right, and kind of made the same mistake here that yes, this is listed as a second-line regimen, but not quite based on this trial. And of course, the other chemotherapy options. And the fact that it's labeling MARIPOSA 2 as a chemo-free second-line option, that's not quite correct based on the arms that we discussed, even though we can say ME plus LAZI is a chemo-free option, but it would not be based on this trial. Okay, and next, the amivantamab plus lazertinib first line after progression. Let's see what it would do. So it essentially mentioned the chemotherapy options. Okay, so one thing I did not see here is datopotamab, and we'll be asking that in a second. And here is kind of a summary. Yeah, there are some evidence for dose escalation, but I agree, confidence level is probably moderate. And clinical trial, certainly never the wrong answer. And of course, the biopsy here. So I think this is a reasonable answer, but there are some omission that we'll be discussing with the AI. Here is a sequencing table. And one potential option here that people may consider is amivantamab plus chemotherapy, depending on how far away they are from the time of progression from the initial chemo. And it correctly pointed out here, rechallenge can be feasible depending on the duration. Of course, whether 6 months or more, it's not as well defined as, say, in other disease types like ovarian cancer. All right, so now I'm interested in why datopotamab deruxtecan was not mentioned as a subsequent therapy since that was approved also. Now, this could simply be due to the fact that it did not quite perform a search beforehand, so there's a temporal gap from the time of the training data cutoff. But let's see what it says. So it recognized that Dato-DXd is an appropriate option, and the omission was incorrect. And it highlighted the trial here support its approval. So didn't quite tell us why it omitted. Let's push it further. So analyze the error as to why Dato-DXd was omitted. So it did mention here, not necessarily because the data came off after the training date, but simply because the other options has denser training data, meaning there are more study out there for Osimertinib and so forth. So the AI favor those since it has more data on this. So there are thinner and less reinforced representation for Dato-DXd. And it's highlighted here as well. It's not simply a cutoff problem. It's a representation density problem, which is something that clinicians need to be aware of, not just for newer agents, but newer class of agent. And here I mentioned another probability, prototype retrieval bias. So it seems like it's a priming issue. So I mentioned is a availability failure. Agents with stronger categorical associations are retrieved preferentially over equally or more relevant agent with weaker categorical priming. So essentially citing that because in the training data, Dato-DXd is typically associated more with other disease type, it did not automatically prime it for retrieval. So again, not simply a knowledge gap or training data cutoff issue. And it's really being quite candid here, which I do appreciate, that it's able to show us its clinical reasoning and the failure modes. Here I mentioned structural scaffolding error. So I mentioned initially organized its framework based on the potential resistant mechanism for second-line therapy. However, it failed to realize that because Dato-DXd is mechanistic agnostic when it comes to resistance, that's why it didn't come up. However, we also know the same thing could be said for the platinum chemos, so I'm not quite sure what's the difference here, besides some of the things I already mentioned. And another thing that I mentioned here, which is interesting, so the anchoring to guideline over emerging evidence. And this is something that we see with the RAG models as well. Because the approval is relatively recent and the guidelines also updated just more recently. They mentioned the likely exists in this training, but there's insufficient reinforcement of it. And I don't quite know what this means exactly, but the fact that even newer agents could be in guidelines, and even though they may be trained on those data, and again, I don't know if Claude is or not, the fact that it's there once may not be sufficient since there need to be reinforcement. And certainly I don't pretend to be an AI scientist or engineer, simply just going through its failure modes. And here are some of its defenses. So yes, it's not a hallucination, it's more of an omission. And interestingly here again, not a knowledge gap in the absolute sense, since it was able to surface those data without explicit search prompting. And also agree it's not necessarily a reasoning error, even though it did anchor on its second-line approach based on resistant data. So here, I think this is really quite useful for what the AI is teaching us about its clinical use. So totally agree that in a rapidly evolving field like oncology, AI does have quite a bit of limitation, whether it's RAG or not. So something that the clinician need to be aware of. And this is probably the crux here. The fact that viable options are omitted, there's not flagged anywhere, and unless the clinician is already aware of it, this may not surface. And as you've seen previously, we mentioned prompting itself is a clinical skill, but also pushing back can be considered one as well. Those only surface after we push back. Here, it characterized pushback as adversarial clinical prompting, which is genuinely valuable. So certainly don't accept the first answer the AI gave you without questioning it. And here it also highlighted something quite important, which we'll explore in future encounters. The fact that I think it has high confidence in some of its recommendations doesn't mean it's right. I quite like its conclusion here. It's not that AI make errors, and certainly, like humans, errors are inevitable. It is that the error was silent and unflagged and would not have been caught without expert interrogation. And this is something that I'm hoping that we can all take away. The more advanced the AI, the more important clinical judgment becomes. So to summarize what we learned from this encounter of these stress tests, is not just whether the information exists within the AI prior to the training date cutoff. It is whether our prompt is able to surface those knowledge from the AI base. The AI clearly had MARIPOSA in its training, but without an explicit search prompt to look for newer data. It did not update the overall survival maturity, and thus probably weighting those data differently. And that may be one of the reasons why the presentation and initial response was incomplete. So it turns out the search first prompt is not a workaround for newer approvals or newer studies. It is a structural requirement for the prompt for any query that the answer may have moved in the last year or two, not just for approvals or guidelines, but the data itself. And certainly that covers almost all of oncology. None of those errors are random. Each one has something that's predictable in its retrieval architecture, the training data density, how the prompt is engineered. So those are things that we need to anticipate. And there are largely things that could be corrected or even avoided. However, similar to all the errors before, it does require current clinical knowledge and clinical judgment to be able to catch those errors and being able to push back at AI to surface a better answer. It's a consistent pattern across the 3 videos now. AI make mistake not because it lacks data. It failed because it's not anchored by the right prompt to use the right data at the right level of recency and completeness. And knowing how to build that prompt to force those retrieval of the right data and being able to push back at the AI when needed. Those are, again, arguably important clinical skills in this new age. However, the basics, knowing the trial data, knowing the clinical knowledge, those are the minimum requirement that allow us to interrogate the AIs. We'll see you on the next one.